Hello. Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. So we'll go to the next slide, please. So the first big news that we have is that in their November monthly update call, Sequoia, who runs, excuse me, is the coordinating entity for TEFCA, announced that the first QHINs will go live on December 12th. So there's not a ton of information available, and it wasn't on their website yet at the point that I did this, but these first QHINs will use the Common Agreement version 1.1. This version doesn't include any fire support, and they have not stated which QHINs will go live on that initial date. But they have put that fork in the sand, so to speak, and that is the date that they expect some QHINs to go live. So I don't know how much more I can say, but if anyone has any questions, feel free to give it a shot. I'll give it a shot. All right, then let's move on to the next item. This just came out yesterday. I've not had a chance to look at it in a ton of detail, but NCQA has proposed some updates and they're putting out for public comment, including a new health equity partner certification program, some updates to existing accreditation and certification programs, and then some updates to their health plan ratings for both 2024 and 2025. So, excuse me, the way they're doing the comments is kind of interesting. You pick which of these areas you want to comment on, and then you pick a subtopic, and you put in a separate comment for that subtopic, and the comments for each of those subtopics are limited to 2,500 words. So some of the subtopics are big, some of them are not as big, but they've decided how they want to slice these things, and then you just put in those short comments. They're all due by January 15th. You can find more information at the link. Any comments, thoughts, questions? All right. Moving on then. CMS has announced some extensions for the No Surprises independent dispute resolution process. Normally, disputing parties have 5 days to respond to requests for additional information from an IDR entity. To refresh your memory, the IDR entity is basically the person who's resolving the dispute, the organization that's resolving the dispute. And CMS has told them that they should grant any extensions that are requested through January 16th. In addition, disputing parties normally have 10 days to submit their offers after an IDR entity is chosen. The offers, that's what each side says. This is what we believe the payment should be. And if on request, CMS has told the IDR entities to grant a 10-day extension to that if it's requested on or before January 16th. You may remember that there's been a lot of churn in this area, several lawsuits. The dispute process was frozen for quite a while. And I think this is sort of a getting back into the groove of things. I could not find any information about this on their website. I got an email directly from CMS with this information. So it does come from CMS. It is trustworthy, but I can't point you to somewhere for additional information about it. Any comments, thoughts, questions? All right, moving on. Next slide, please. Thank you. So CMS has also put out a toolkit for consumer advocates around No Surprises. Looking at it, I would think it would be very nice just for patients and consumers, period. But it was designed for organizations that are advocating on the behalf of patients. It's a very long toolkit. It's a PDF file that's 133 pages. And it basically assumes that you don't know much about No Surprises from the start. So it has an overview of those components that are consumer facing and billing related, and also talks a bit about how they interact with state laws. So some of it is just collating together information that's already been out there, some of the fact sheets, some of the decision trees, their sample consumer forums. But then there's also sections on how to help consumers protect their rights and the complaint process and some other bits and pieces. And so if you're interested in refreshing your memory with an overview or looking at the consumer protection specifics or how to file a complaint, you can find all of that in this toolkit. Any questions, thoughts, comments there? All right, moving on to the next thing. So this is a really short document and I wasn't sure if I should include it at all, but it's basically a really short overview of information that's already available on the different ways that Medicaid and CHIP can support social services. And so it talks about the 1115 waivers. There's also 1915 waivers for home and community-based services and something called health service initiatives that are part of CHIP. And it's literally like 3 pages long, and it doesn't really do much more than just sort of provide a really conversational overview of what's out there. But if you're interested in looking at it, you can find it at that link. Any thoughts or questions, comments there? All right, moving on to the next slide then. ONC has a new blog piece where they talk about the digital health divide. What's interesting is that it's actually not about the digital divide for individuals, but organizations. And so it's really about the divide in interoperability capabilities of different organizations. And so they take a look at different ways to slice mostly hospitals. And they note that rural hospitals are 23% less likely to use interoperable data exchange than urban hospitals. That hospitals in the areas with the highest social deprivation, I keep wanting to say deprivation index, were less likely to be interoperable, as were critical access hospitals. But what was interesting was that they said other indicators of disparities besides the social deprivation index didn't show the same differences. And so they talk about 3 or 4 other measurements that are often used to look at where the most critical needs are in areas where disparities show up. And this particular disparity was only there for the social deprivation index and not for those other factors. But what they do point out is that the populations that are most likely to use emergency care most often, most likely to have fractured provider experiences, where they go to different places for different care, are also the most likely not to have a coordination of care between their various care sites happen more easily. So you can find the post there. It was interesting. There's some graphs on a couple of those factors if you're a visual person, and they talk about what those other normal indicators of disparities are that didn't show up here, stuff like that. So any comments, thoughts, questions there? Excuse me. All right, then let's move on. So the FDA has put out their 2024 plans and priorities document, and it's split into A and B lists, with A being the highest priority and B being if we can kind of list. And some of the A list items were interesting. There were several things related to AI, including They also split the list between final and draft guidance. And so final guidance on marketing submission recommendations, on change control plans for software that uses AI or machine learning. But they also had draft lifecycle management and pre-market for software using AI and ML. When they say device software, just in this context, remember that that could mean a physical device that has software on it, or it could be just software, because the FDA classifies some software as a medical device in order to oversee it. So other things that they have in there are cybersecurity guidance for cyber devices, how real-world evidence should be used for medical device decision making, and then the last two were data-driven, specifically data-driven, use of sex and gender data in medical device clinical studies, and patient preference information, including device labels, which ties right into the other thing that we looked at last week, which is the patient medical information proposed rule that the FDA had out. So you can find the full list at that link. It's kind of interesting. I thought these were the real highlights, though. Any questions, comments, thoughts there? All right, well, if you go on to the next slide and pause for a second. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@mahealthdata.org. That email address is also on your screen.